happy Friday night. We're doing a little live chat here tonight for the community, for the GLP-1 community. We talk about all things Wegovy, Saxenda, Victoza, Trulicity, Mounjaro, Zepbound, and we even talk about the investigational drugs like AMG 133 or Meritide, Survodutide, Pemvidutide, all of the utides, Retatrutide. That's what we talk about here on this channel. And so what we're doing tonight is just a little live chat. We're going to talk about all the news in the world of incretin mimetics. So what's going on in the world of Mounjaro, Ozempic, Wegovy, Saxenda, Victoza, Trulicity. You're welcome, Leslie. We're streaming over on TikTok. We're streaming on YouTube. So welcome. If you're new, drop an N in the chat next to your name. Let me know that you're new here. I'd love to welcome you by name. We're going to get into some of the news topics of the week. One of our great contributors on the pin, hey Bridget, hey Daphne. Sarah is down 125 pounds. She's an OG. Melissa's down 164 pounds. These medications are absolutely changing lives. Absolutely changing lives. And so you start to understand why a guy like me creates content about these medications. You may have heard of Ozempic, you may have heard of Wegovy or Zepbound being the newest one. So these are medications that belong to the incretin class of medications. And the incretins are hormones that are made in our gut. They're responsible for helping us feel full when we eat. They're responsible for delaying gastric emptying. It reduces the amount of sugar that your liver makes, requiring less insulin on a baseline, creating an environment in your body that is more conducive to losing weight. So that's what we talk about here. J. May, Robbie, welcome. Good to have you here. Thank you for jumping into the chat tonight. Bridget's down 125 pounds. or 115 pounds. It is just amazing what people have been able to accomplish with this tool in their arsenal. It's like it's finally correcting what has been metabolically broken and creating an environment that is conducive to help people lose weight. So absolutely just amazing. Amazing. So thank you all for being here. Glad to have you here tonight. We're going to jump into the news here shortly. Again, we talk about all things Wegovy, Saxenda, Victoza, Trulicity, Mounjaro, Zepbound. Let me know in the chat which medication you are on. I myself am on a medication called Mounjaro. I've been on Mounjaro and Ozempic both, but much prefer Mounjaro. It's a much better medication for me with my type 2 diabetes and with obesity. Do you know if certain doses of Tirzepatide help you feel fuller for longer? So it's going to be just depending on your own biology. I mean, the 15 milligram is where people saw the most weight loss in the Surmount trials. Let me pull up some news here. We'll get going here in just a moment. Make sure that if you're over on YouTube that you hit the like button. Make sure that you subscribe if you're not already subscribing to the channel. We talk about all the news in the world of incretin mimetic therapies. That's what we do over here on the pen. So interesting, one of the frustrating things, I see you join Fridays. Thank you, Mundo said blessings upon blessings. Thank you. I've got some happy birthdays in the chat. Thank you for the birthday wishes. I appreciate that as well. Today is my birthday, 39 years old today, 39 years young, I should say. So if you want to do me a favor, hit the subscribe button, follow the live creator. If you're on TikTok, hit subscribe. If you're on YouTube, Carolyn's on Mounjaro. Carolyn's gone from 215 down to 153. Just absolutely amazing. Thank you, Jenny, for the birthday wishes. Greatly appreciate it. Let's see here. Some of the interesting news. So the Mounjaro, which is the brand name of Tirzepatide for the indication of type 2 diabetes. And interestingly, with Mounjaro, it's not being rebranded over in Europe for the weight loss indications, but we did see it approved in England for weight loss. And that's really good news for those of our friends across the pond who are going to be able to now get Mounjaro for weight loss. Now, the interesting thing over there is the obesity indication for Mounjaro is a little bit more stringent than over here, where your BMI has to be 27 with a comorbidity. Over there, it's all the way up to a 35 BMI with comorbidity. Unlike Wegovy, there should be a little bit more accessibility to Mounjaro versus Wegovy, because Wegovy you had to see a specialty weight loss clinic, and with Mounjaro you're going to be able to get it through your general practitioner. So if you're over in England, let me know that you're here and in the chat. Hey, Lee's watching over on YouTube. Good to have you here, buddy. Thanks for being here. A lot of these later night posts that I do or that I do get a lot more of our West Coast friends in here. So if you're from the West Coast, put West Coast in the chat. It's good to have you in the chat tonight. And love connecting with my friends on the West Coast. So Lee, good to have you here, buddy. I'm doing a live tonight. I took Thursday night live off. West Side says join Fridays. I took the night off on Thursday night, so we did not do a live show on Thursday. We did a sort of a replay episode of an older episode of On the Pen. And so I told y'all I would get on and do a birthday night live. So tonight, as one of my self-indulgent things for the night, I'm doing this birthday night live here. So good to have you here. Lawn Guy Land here. That's awesome. Awesome from Los Angeles, California, West Coast. Awesome, yeah. So a lot of our West Coast friends. Mongoose is from the West Coast. Miss Moni is from the West Coast. Good to have you here. Thank you for being here. So let's get into some other news. So we saw that really good news for our friends in England. Not so good for those of us who are dealing with shortages over in the United States. More news this week that Eli Lilly is shipping more Mounjaro to Japan also. Thank you, MM says I'm the man. I appreciate that. So seeing Lilly ship more Mounjaro to these ex-US markets is a little bit frustrating if you've struggled to find your medication. Now, we did find this past couple of weeks that Eli Lilly updated the shortage list to show that many of the doses were coming back online, the 5 and the 7.5. Interestingly enough, I'm hearing through the grapevine that Ro's tracker tool is actually showing that there's not really been an increase in the availability of the 5 to the magnitude that you would expect if it was off shortage. But another plug for their tool, you can go to ro.co and find their supply tracker, or just Google GLP-1 supply tracker. When you go to that website, you can actually report your shortage that you're experiencing for the dose, and they'll submit that shortage report to the FDA, and the FDA then will kind of put that back on the manufacturer, like you're saying it's not in shortage, but here's these 500 reports around the country that people can't find their 5 milligrams Zepbound, and Marianne says she can't find her 5 milligram, and that's exactly sort of what I hear that they're hearing with the Ro tracker tool, is that the 5 milligrams Zepbound is nearly impossible for people to find, even though it's been taken off of the FDA shortage list. So interesting news there. Interesting news on the GLP-1 front. Would you know that GLP-1s made up 9% of medication costs for employee insurance plans in 2023. So you think about that jump, and that is absolutely a huge jump in the cost for employers. So it's going to be interesting. We're seeing some interesting things. Like I saw a member shared with me this week that their PBM, Blue Cross in Michigan, is going to stop covering GLP-1s for weight loss. We've seen CVS Caremark customers now having to enroll in a health plan with a health coach. That's going to be a prerequisite for them being able to get their medication. So you're seeing these PBMs move to definitely block access to these medications, which is super, super frustrating. Marlo says happy birthday. Thank you. Linda says happy birthday. Thank you for the birthday wishes. I appreciate that. Cat Dad, welcome over on TikTok. So 9% of medications on employer plans came from GLP-1 medications. So that is a huge, huge jump for employers. Compound is the way to go, says Bridget. Compounds are 100% going to continue to be a massive, massive necessity in the supply chain. Absolutely necessary, and that's why it's so important to understand the difference between 503A, 503B pharmacies, as well as research grade chemicals. There are differences between all of them. 503Bs, you know, in times of shortage, this is an interesting fact, but in times of shortage, when a manufacturer has a drug go on the FDA shortage list, they have to share their formula for making their medications with 503B pharmacies, because 503B pharmacies exist to help the supply of certain medications when they go into shortage. That's like a huge reason for their existence, because they can manufacture drugs on scale, right? 503A pharmacies are individual scripts. they don't have the ability to manufacture en masse, right? And so oftentimes 503B pharmacies are supplying to hospital systems to help them with life-saving medications. Of course, these GLP-1s are no different. They are in a shortage. 503Bs have those exact recipes from the manufacturer to make and are really a mandate by the government to exist to help in times of shortage. So it's important to sort of know these distinctions between these different kinds of pharmacies. Moving on to some other news here in GLP-1s. We saw this week that Eli Lilly's CFO, Anat Ashkenazi, who has overseen some of the largest growth in Eli Lilly's history vis-a-vis these GLP-1 medications, left Eli Lilly and will now be working for Alphabet, the parent company of Google, in their AI department. So a huge bump for Anat Ashkenazi. So congratulations to her. I really, I've heard Anat speak at a number of Lilly events over the years, and I feel like Anat is one of those rare beating hearts within corporate America. She seems to be a really compassionate person. And so I think that's actually exciting to have her move over to Alphabet and sort of be in this AI space, because I think it's important to have people with beating hearts who think about individuals, who care about individuals, kind of leading the charge on the development of AI, which is, coming fast and furious. So, so very, very interesting. Leslie says, in basic terms, they own the recipe, and a compounding pharmacist can take the recipe and recreate the same. 503B pharmacies are sort of mandated, and actually pharmaceutical companies are mandated to give their exact recipes over to the 503B pharmacies. So, and there's also strict rules on where they can source their API. Not the same exact for 503A pharmacies. Is there a shortage for Ozempic? Tracy says, thank you for all you do. You're very welcome. Thank you. Tammy says, happy birthday. Thank you. Deborah says, happy birthday. Thank you. I appreciate that very, very, very much. 39 years young today. So congratulations to Anat Ashkenazi for moving over to Alphabet. That'll be an interesting transition for Eli Lilly in the middle of some unprecedented growth to replace a CFO, right? But she's pretty awesome. Diana, thank you. Daphne, thank you. I appreciate the birthday wishes. Let's move along here in some of the other news for the week. One of the things that we learned this past week is that Novo Nordisk has resumed their marketing campaign for Wegovy. So all of a sudden, you've got Wegovy, which is in an FDA shortage. I still believe that there are doses of the Ozempic product, the diabetes version of semaglutide, in an FDA shortage, and you see them actually running national advertising campaigns called The Power of Wegovy. And so what do you all think? Drop it in the chat. Let me know what you think about pharmaceutical companies being able to advertise their medications just in general, but especially in times of shortage. I believe the United States is only one of two companies that actually countries that allows the advertising of medications at all. So I think that's a pretty interesting thing. So yeah, you do see tons of Wegovy commercials everywhere now. And don't get me wrong, it's an excellent medication, but to see it advertised right now is a bit frustrating. Most of these telehealth companies use 503A. That is correct. And I don't really know. I think there are only, I'm not even sure of any 503As or 503Bs that are doing Tirzepatide yet. So it'll be sort of a TBD on that. So does that mean that 503A pharmacies Tirzepatide is subpar? No, not necessarily, but it is important to understand the distinction between the two. 503B pharmacies can manufacture on scale, and they exist to create medicines in times of shortage. This is sort of their mandate from the federal government. It's why they exist. 503A pharmacies exist more to fill, to fulfill medications that are more compounded, truly compounded, like you take two compounds and put them together. So you take, well, the recipe is just a long chain of amino acids. It actually exists within the patents for these drugs. So if you look up the patent for Tirzepatide or semaglutide, you're going to see the sequence of amino acids there. So it's public knowledge. But how they make it, I think, is unique. Like one of the things that we learned this past week is that semaglutide is actually made from yeast and is a very specific process, and only Novo Nordisk manufactures it. So they don't have subcontractors manufacturing the API at Novo Nordisk. So that is a really sort of interesting spin on things. Tirzepatide is still new enough that you haven't seen quite the amount of dupes on the market that you do with semaglutide. When do you think they will approve 20 and 25 milligram for Mounjaro? So those are in clinical trials now. We broke that news that those are the 2 doses that they're testing. That comes from some insiders that are familiar, deeply connected to the clinical trials that fed that information to On the Pen. We broke that news, I don't know, several weeks ago. We are still off. We will probably have the 20 and 25 milligram, assuming everything goes well in trials, around the same time that we'll have Retatrutide in 2026. Late 2026. So those will come out at a very, I did a video on it, and I did the numbers, and it was going to be really close. I remember that. I'm not sure which comes first. I think maybe the Tirzepatide will come slightly before we see Retatrutide, but don't hold me to that. But they're going to be around the same time, probably late 2026. So some interesting numbers. If you want to break down kind of playing off how much these drug companies spend on advertising. So in 2023, the number 5 advertising spend was Rybelsus at $191 million. The number 6 advertising spending was Ozempic at $187.4 million, which is just astounding. So you see most of these ad dollars spent on social media platforms like YouTube and Facebook. And I'm sure that, especially if you're watching over on YouTube here and you watch any of my content, you're probably going to see a lot of these advertisements on this type of content where we talk about these medications. Tammy says she was put on Ozempic after she couldn't find Mounjaro and it made her sick and she couldn't take it anymore. And others have said that that's not good for them either. I think the interesting thing about that is that people do respond differently to these medications. So if you're switching from one to the other, it's like, don't try to find an equivalent dose necessarily, especially if you're going from Mounjaro to semaglutide. Definitely want to start low and slow. You can always work your way up, but you know, people have gotten very sick jumping over to high doses, especially again going from Tirzepatide to semaglutide. Could compounding pharmacies give higher doses before 20 and 25 come out? You may see that, Mongoose. I mean, you're already seeing telehealth companies that are offering Retatrutide. You're seeing telehealth companies that are offering oral Tirzepatide. Oral Tirzepatide just entered into a clinical trial with a company that has a technology called Dehydratech, and Dehydratech extracts the API from an injectable medication and sort of wraps it in these fat-friendly molecules to allow oral absorption of the medication and oral bioavailability. You actually see some telehealth companies offering some stuff that's only in phase 3 clinical trials. So I don't think it's beyond the realm that you could see some of these telemedicine companies prescribing higher doses of these medications. Now, is that right? Is it ethical? Is definitely a conversation for another day and another time. But I think you will see that. Whether it should happen is another story. How can companies offer Retatrutide? So it's a great question, a question to which I do not have the answer. I don't know how ethically they can do it. They have not. Retatrutide is the triple agonist that is in phase 3 clinical trials with Eli Lilly currently. So ethically, how you offer a phase 3 drug to somebody when it hasn't undergone proper testing. You know, the other thing to mention that I feel like is worth mentioning when we talk about Retatrutide is because it acts on glucagon. Glucagon is a cardiac stimulant. And so it's going to ramp up your heart rate. And what they've seen in these phase 3 trials and already reported on is that when you get up to the 12 milligram, thank you for the gifts over on TikTok. Thank you. I appreciate that. You see actually an increase in heart rate by about 10 beats per minute. There were marginal heart rate increases with pre-existing GLP-1s. Even with Tirzepatide, you saw 3 to 4 beat per minute. But Retatrutide gets you all the way up to 10 beats per second increase. And so it's dangerous for a lot of people because they're getting into these medications perhaps with pre-existing heart issues, and long term these medications have been shown to be cardiac protective. That's great news, right? We're seeing that with the SELECT trials. We're seeing Tirzepatide trials, which will report on the cardiovascular outcomes for people with heart failure with preserved ejection fraction. We'll see those trials come out a little bit later this year. Hey Taylor, how are you tonight? but long term they're cardiac protective, and certainly I think retatrutide will be the same. But the thing is, in the early stages, it does tick that heart up. So if you're somebody who struggles with tachycardia or has a high heart rate to begin with, that is something to be aware of and to just be cognizant of, because these telehealth companies are prescribing this now, and I don't know that in all cases they understand that it acts on the heart in that way. Certainly, retatrutide holds a ton of promise in the treatment of fatty liver disease and poor metabolism. Leah, thank you for the gift on TikTok. Really appreciate the gifts. Not ever expected, but they're always appreciated. So thank you for honoring the work that I do in that way. So yeah, I do think you will see higher doses of tirzepatide prescribed, because you're already seeing other phase 3 things being offered by some of these telehealth, and I think it's sort of a race to the bottom. I think it's like, there's one part of me that believes people should have the ability to make determinations with their doctor about what they want to take, but it's sort of like, where does it end? If you're going to just all of a sudden start offering phase 3 clinical trials, why do we even do them? Why do drug companies have to go through these very costly clinical trials if people can sort of just subvert that, right? And so it opens up like a weird sort of debate about the necessity of a phase 3 clinical trial if you have a sector of the market that can just sort of subvert that altogether. Now, certainly people are not going to go to a phase, or drug companies are not going to go to a phase 3 trial if the drug did not show safety in phase 2 and efficacy. But phase 3 is often where they get their titration schedule and the safety of maybe a little bit higher dosing figured out. And so I don't know how I feel about these telehealth companies offering investigational medications, but I do believe that doctors and patients should be able to make decisions for themselves, and if it's available and if they could benefit from it. I believe that people do have the right to try, but they need to be informed, and I just worry about that glucagon component with retatrutide and people not understanding the fact that glucagon receptor agonism is sort of a novel. Glucagon medicines aren't novel, but long-acting glucagon is a novel approach to a medicine. We've never had long-acting glucagon agonists. We've had very short-acting to help people who have like hyperglycemia. People who come in with extremely low blood sugars are given fast-acting glucagon to raise their blood sugars, but we do not have any clinical trial data on sort of this long-term effects. So you see some of the other popular peptides that people are taking as far as phase 3 investigational medicines. You see CagriSema is being offered in some places. Certainly from the research grade, you're seeing all sorts of stuff. I've seen Mazdutide, which is I believe that's GLP-1 GIP. It's this joint venture between Eli Lilly and another company that escapes me, but one company holds the rights to sell it in China, and that's probably where it'll be released. I don't think it'll be released here, but because it's too close to Tirzepatide. But Mazdutide, I've seen CagriSema, I've seen Cagrilintide by itself being offered. I mean, it's the wild, wild west when it comes to research peptides. But the thing is, it's like I said, it's sort of a race to the bottom. You see telehealth companies starting to offer this stuff too, and it's a slippery slope. Like if I don't know. I don't know what to make of it 100%. It's glucagon. Okay, closer. Thank you. So more like Survodutide, right? So it's closer to Survodutide. I wondered. Thank you for the question, and thanks for being here, Cloakster. Good to have you here on the live stream. We're kind of up late, so shout out to all of my West Coast folks that are joining tonight. Currently on 12. Didn't have any weight loss. Started so far 14 in 7 weeks. Doctor wanted to increase to 15, but it's been unavailable. If you're doing well on the 12.5, I don't even see a need to switch if I were you. Once a month. The once a month medication is actually AMG 133 or Meritide. So a lot of these start to sound the same. Mazdutide, Meritide. Meritide is the once a month, and hey Vicky, how are you tonight? It's once a month. It's a GLP-1 and GIP antagonist. So it's GLP-1 agonist and GIP antagonist. So it's sort of the opposite of Tirzepatide. It's also delivered via monoclonal antibody, so the half-life of it is like a month. But they're also tweaking that again in phase 3 clinical trials to try to maybe even extend that out longer. The thing is that they're finding with GIP antagonism, where they're blocking the GIP receptors, you still see weight loss, whether you block it or whether you activate a GIP receptor. Weird, right? But what they're finding is there's more of these emetic side effects, right? Vomiting, diarrhea, nausea, sort of these gastrointestinal issues. Really high in phase 2 clinical trials with the highest dose, but obviously that's not super fair. It's not a huge number of people. But hey, Sabrina, welcome. Thank you for the gift. I appreciate it. Thank you all for being here. If you're here, it's a good reminder to hit that like button. If you're on YouTube, welcome. Hit that subscribe button. Please, if you would, stay in touch with my content. If you're following over on TikTok, hit that like, that love button. Send this to somebody who might find it interesting, and make sure you follow the live creator. Structure Therapeutics in a 12-week phase 2 clinical study on a tablet formulation of a GLP-1, right? And so this is actually another competitor to orforglipron. Orforglipron, small molecule GLP-1 medication in the works from Eli Lilly, phase 3. Small molecules, interestingly enough, I think the pharmaceutical companies are really going the way of the small molecule GLP-1s versus peptides. So all the GLP-1s that exist right now are peptides: Maritide, liraglutide, survodutide, dulaglutide, Tirzepatide, semaglutide. Everything ends in tide because they're peptides. Long chains of amino acids, right? That's all they are. Long chains of amino acids wrapped in fatty lipids. That's, I guess, saying the same thing twice. Wrapped in a lipid to sort of help slow the absorption of the medication over time, right? Orforglipron is a GLP-1 pill that's actually a small molecule, so it's not a peptide. Two things why they like that. First is absorption, right? Because an oral peptide doesn't have a lot of bioavailability. 50 milligram Rybelsus will be hitting the market a little bit later this year, probably in July. But 50 milligram Rybelsus, if you think about it, is 350 milligrams a week. And at 350 milligrams a week of oral tirzepatide, it gets about the same results as about 2.4 milligrams injectable. So you have like 145 times the amount of active pharmaceutical ingredient in a pill to equate out to the injectable dose, right? And so a ton of API, active pharmaceutical ingredient, to get those levels of results, where with orforglipron, the small molecule, thank you for the likes over on YouTube. I really appreciate it. It's just a little bit easier to manufacture. I mean, they're complicated, don't get me wrong, but to scale out, you don't need as much API. The other thing is that you can mass produce it, right? And it can't be duped like a lot of these other medications can. Peptides are very easy to dupe. Small molecules, not so much, because it relies on a lot of chemistry to make. Where, again, like we talked about earlier, how, yes, a huge lack of oral bioavailability in a peptide. It's very unstable, right? A peptide is by nature very unstable. And so, hey, Visible Scientist, welcome. Thank you for being here over on TikTok. Says happy birthday. Thank you very much. It is my 39th birthday tonight. YT is, do you happen to know a good? Yeah. So, the really awesome thing about the GLP-1 community and those who take GLP-1 medications is we're all here trying to learn a little bit more about the medications we're on, to share community with each other. And I just really appreciate each and every one being here tonight. I thank you for all the birthday wishes and the love that you're giving me over in the chat on TikTok. Thank you, Sabrina. Thank you, Samantha. Invisible, it's always good to have you here. The Real Anchorman says, got to get you on my show soon. Which Anchorman? Are you the one out in Syracuse? Can't remember your name. Scott, maybe? Thank you for all the information. You're so informative. Oh, thank you, Leah. I appreciate that. Samantha, thank you for the birthday wishes as well. Appreciate that. Oh, Ancient Dave, that's right. So Structure Therapeutics has their own, basically, Mimi, thank you for the super chat. I appreciate that over on YouTube. Thank you. Let's see here. NBC, Buffalo. Yeah, and your name's Scott, right? Do I have that right? So anyways, thank you for the likes over on TikTok as well. I will finish this thought one way or another. GSBR 1290 is Structure Therapeutics oral formulation of a small molecule GLP-1 that will be sort of in competition with orforglipron. But orforglipron is going to hit the market in 2026. And this one, not for a long time. DJ with a $10 super chat on YouTube, thank you for the gifts. Mimi and DJ, thank you for the gifts. I really appreciate you honoring the work that I do in that way. I always appreciate it. Never expect it. I don't expect anybody to come in and give gifts, but when you do, I appreciate them. And I appreciate you honoring the work that I do in that way. Thank you very much. Let's see here. An interesting stat, right? So if you're living with obesity, you have over 10 years living with obesity, you have an up to 60% increase in the risk of heart attack and stroke. So when we talk about these medications, I think not only should we be talking about them in terms of what they can do to sort of reverse obesity or treat obesity, but is even a prophylaxis against. Oh, Sabrina with the $25 gift over on Cash App. Thank you for that, Sabrina. Y'all are too good to me. Thank you very much. I really, really appreciate your gifts. Thank you, thank you, thank you. Sabrina, you're so stinking generous. But we think of that as being sort of a prophylaxis against obesity for those who are genetically predispositioned to it. I just think that the evolution of these medications is really promising, and the oral formulations of these, I think, is the sleeper when it comes to being able to treat a global problem, the global problem that is obesity. And we talk about cleaning the tank, right? Fixing the food environment. That is an uphill battle, and I think it's much easier to mass produce these medications than it is to change our food system. I'm not saying that both don't need to happen and that both are mutually exclusive, but I think that the oral formulations and frankly compounds, right? Because drug manufacturers in the near term, let's say the next 5 years, drug manufacturers are never going to be able to meet demand for these medications. Even at the prices they charge, they're not going to be able to meet demand for these medications. And I think that compound medications are going to be a critical, whether you like it or not, a critical part of being able to bring access of GLP-1 medications and treatments to people who need it, right? And so far as the powers and players in the GLP-1 game right now cannot serve the market, I think that the compound pharmacies, that is why they exist. That's why 503B pharmacies exist, is to help medications in times of shortage. Megan Pierce over on YouTube, who is smarter than everybody, says that this channel is so wrong. I would love to hear more from you, Megan. Why don't you pontificate for a minute? The floor is yours. Cloakster with a $19.99 super chat over on YouTube. Thank you, buddy. I appreciate that. Thank you for the gift. Super kind of you. Thank you for all that you contribute to the YouTube channel. I really, really appreciate you, buddy. Di-do-5 in KPP. You gotta love those long names you can't read. Diabetic, been on Ozempic for 2 years, only lost 10 pounds, gained back 7. Perhaps Mounjaro would work, right? So Mounjaro is the next generation of incretin mimetics, whereas it combines GLP-1 receptor agonism and GIP receptor agonism. So you get two sort of incretin hormone receptors that it's acting on. And for that reason, some people see a greater level of weight loss. Now, in the Surmount trials, you basically saw two different studies, right? One where people achieved 22% weight loss and one on average, and one where people achieved about 15% weight loss on average. The only difference is one group was not diabetic and one group was diabetic. So in general, people who are diabetic are so metabolically ill that these medications are having to do so many other things metabolically to help people out. Real Anchorman says, why don't telehealth use 503B? Many do. So for example, the telehealth company that I have worked with to get my medications from, and I'm on branded medication, so I actually take name brand Mounjaro, but they use 503B to source their compound semaglutide. They don't offer compound Tirzepatide because there are no 503A pharmacies, or sorry, 503B pharmacies manufacturing it as of current. That will all be changing soon, I'm sure, so I will keep you posted on that. I think the reason is just ease, availability, and I think 503B pharmacies are a whole nother sort of animal because 503B pharmacies are typically selling to pharmacies and hospitals. where 503A are filling an individual script for an individual on an individual basis, right? So we talked about earlier, 503A pharmacies are designed to make an individual script for an individual patient. The way that they've historically been used in a 503A pharmacy is you take one medication, combine it with another. So you would take perhaps some sort of cream for a fungus, and you would combine multiple compounds and put it in one cream, right? That doesn't exist on the market. They all exist individually, but not together. And so they compound it, they put it together. The other thing that they've done is they've taken, drugs that are, name brand, and they've, made them without certain dyes or preservatives, because sometimes people have sensitivities to those kind of things. So that's what 503A pharmacies have historically existed for, where 503B pharmacies, there are far fewer 503B pharmacies than there are 503A pharmacies, and the 503B pharmacies have been basically built to help with our medical infrastructure in this country, so that when medications go on the FDA shortage list, there are manufacturers in place to manufacture those drugs that are in shortage, especially life-saving medications like oncology medications and things like that. So they're part of our critical infrastructure of our country. And that's the difference sort of between 503A and 503B. I'm sure over time 503B pharmacies will be manufacturing Tirzepatide, and perhaps some already are, but as of my last check, there weren't any that were doing it. The reason I said your channel is wrong, because people don't need to take medication to lose weight. I beg to differ, Megan. Many people do, right? Because what we've learned about obesity is that again, not everybody who is overweight has obesity. But for people living with the disease of obesity, it is a metabolic disease. It's been recognized by the World Health Organization since 1942, I think, maybe 1948. It is a disease, and it is a disease of metabolic disorder. So when you have the disease of obesity, you have metabolic dysregulation. And these are the things that medical science has learned. There are a whole family of hormones called incretins, right? Incretin hormones are the hormones that your gut makes in response to eating nutrients. And so some of these hormones are like GLP-1 is one of those big hormones. And if you have obesity, you're dysregulated in your incretin hormones. And so what these peptides do is they just bind to those receptors and give people what you who do not live with obesity have, right? And that is a regulation of these hormones, so that your body tells you when you're full. Your body tells you, metabolic modulators. That is what these medications are. They're not weight loss shots. They're metabolic modulators. And they weren't designed for people who just need to lose a few vanity pounds. They're designed for people who are metabolically sick, and sick people are being treated now. And so our mainstream culture does not like that narrative, because there is a social currency in being somebody who doesn't struggle with weight, right? You struggle with weight because you just don't have the willpower to eat more, eat less and move more, right? But nobody has dieted and attempted to lose weight more than somebody who's lived with chronic obesity. So I beg to differ with your point of view on that. Not only is people who have the disease of obesity metabolically sick, but it leads to other things that you can be genetically predispositioned to, like type 2 diabetes. That's when the wheels are completely off metabolically. You'll see people dealing with fatty liver disease and high glucose numbers. Your fatty liver, will reduce the amount of vitamin D in your body. And so there's all these things that happen hormonally and metabolically that really we don't have time for that old tired argument of people just need to eat less and move more. So we're here to educate. So I don't mind that people come in with that old mentality, but I don't want you to leave the same way. I want you to leave with at least a little bit of education about the fact that, as Real Anchorman pointed out, these are metabolic modulators. They're mimicking hormones that naturally occur in your body, and they exist in your body, and they're normal if you don't live with obesity. But if you live with obesity, you don't make your GLP-1 production, your incretin hormone production isn't the same as somebody who's not metabolically sick. Megan with a $20 super chat over on YouTube. Thank you so much for the gifts tonight. Really, really appreciate it. Real Anchorman says that these medications have changed his life and nothing else has worked. That's amazing. I'm so happy for people. I mean, listen, Megan, if you're still here, thank you for being here, in all honesty. And not Megan Foy, but Megan Pierce. So Megan Pierce probably has a great channel. Please go over and follow her. I'm sure it's loaded with great content, because she seems like she knows everything. So you definitely should check her out. But Megan Foy, thank you for the $20 super chat. Really, really appreciate it. So let's see here. Uh, Rakisha says type 2 diabetic has lost over 108 pounds and now can eat fruit without your sugars jumping. One of the things, Rakisha, that I've said about these medications is that the gift of Mounjaro for me, at least initially, right, was that I could eat normal people portions, normal people food, and feel normal people full. And as a type 2 diabetic, that is such a liberating thing to experience. Thank you again for all the gifts. Holy smokes, over on YouTube tonight. Over $52 in super chats. So thank you for the gifts tonight. Thank you for honoring the work that I do in that way. I greatly appreciate it, because all my work relies on your gifts. So those who choose to do it, appreciate it. Sabrina with the big gift over on Cash App too. So thank you very much. Jacksonville Kid says, let food be your medicine, or let medicine be your food. Okay, so this is the argument. And I love this, because what's happening, for those of you who are watching on YouTube, who watch all the time, what's happening here is that YouTube, when I go live on a mobile device, it opens up the live video to the shorts feed. And so we're getting to talk to some people who are outside of the bubble of our community. And I love to take the opportunity to just invite people in to learn a little bit if they have the capacity to listen and learn. Most people don't, they're in and out. But one of the things at Jacksonville Kid that I would say is, absolutely, there's a component to our diet that contributes to obesity. There are foods in our system that are toxic to our bodies. 100% there are, but there are a whole host of reasons why people use those foods, eat those foods. Sometimes it's accessibility, sometimes it's addiction, sometimes it's a lot of things, right? But one of the things that I think is important to understand is that once people experience metabolic sickness and the wheels have sort of come off metabolically, I think it's important to understand that at that point, the diet is just not going to 100% fix it for everyone. Here's a perfect example, because Jacksonville Kid, I imagine that you would probably agree with me that ketogenic diets, or diets that are low in carbohydrates, can help somebody who are metabolically sick. Agree or disagree? Probably agree, right? So when I was diagnosed with type 2 diabetes in the fall of 2021, even after yo-yoing on keto for 20 years of my adult life, which I think contributed to my jacked up metabolism, the yo-yoing on the keto, I did a full year of strict keto. My body got my blood sugars under control. All right, my blood sugars were, and I took no medicine at the time, my blood sugars were controlled, but I went from 319 pounds to 312 pounds. So I lost 7 pounds. So you tell me why? Why was that, right? When you're metabolically sick, your body acts differently. The eat more, move less mantra, what has that done for our country? What good has the eat less, move more mantra done for our country? We have more obesity than we've ever had before. We have more metabolic disease than we've ever had before. But now that we have found a way to re-regulate a broken metabolism and a broken sort of incretin hormone environment in our body, it's taken away social currency from people who don't struggle with obesity. And I think that's where a lot of this stuff comes from, is that people who don't struggle with obesity, there are a segment of them that feel better about themselves because they don't. And when people get healthy, and when people are able to get to a place where their body has an environment in it that is conducive to weight loss, right? Because you've brought your blood sugars down, you've brought your insulin levels down in your body because your liver is no longer making glucose in overdrive. That's one of the things that happens when the wheels start to fall off metabolically. And one of the things that these medications help to fix. So you create an environment that's more conducive to weight loss in somebody who's sick and resistant to weight loss. That playing field gets, leveled out, and people no longer get that that benefit of that social currency, right? So that, I think, is very threatening to a lot of people. And I think that's what you see again when we get people from outside of the GLP-1 community that come in to this community, and they see their social currency withering away, right? And so I think that's very That's a very intimidating thing for a lot of people, and one of the things that makes them resistant to this, right? Because you know, it's just sorry, it is what it is. My Alex Jones' little brother. I haven't started crying yet, and I don't think the feds are about to raid me. And inflammation as well as other comorbidities. DJ says, "Thank God for scientists and researchers who are working to help us live abundantly and healthy." Absolutely, absolutely, right. I'm not denying that the food environment in the United States is bad. I'm not denying that we don't allow things in our food system that are toxic and harmful to people's bodies, right? But we're not going to fix that overnight. And one of the things that these medications do is they help to correct something that's already broken, right? Already metabolically broken. All you have to do is jump into these live streams, whether on YouTube, TikTok, wherever people are doing content about GLP-1, GLP-1 and incretin mimetics, and see how their lives have changed, right? And if you can't look at that and see what's right in front of you and say there might be something to this is helping people, then it probably is more you're threatened by it, right? And I think that that is the reality for a lot of people. If you're enjoying this live, please like it, share it, save it, send it to somebody who might also enjoy it. If you're on YouTube, hit that thumbs up if you would. If you're over on TikTok, hit that thumb. Like, one of the things you can do is just work out your thumb there and hit that love button. That'll just, give the TikTok algorithm a little bump for this video. Thank you for those who have been here tonight, hanging out with me for the last 45 minutes. It's been a pleasure. To reintroduce myself, I'm Dave Knapp, man on the Mounjaro. I host a weekly talk show called On the Pen. On the Pen Live is a community talk show where we talk about all things similar to what we're doing tonight. We go through the news in incretin mimetics. We go through the news in obesity and type 2 diabetes, medicine, and we have a good time. We hang out in community, we laugh, and enjoy each other's company. And then we have usually a medical guest that comes on that shares about their perspective on GLP-1s or obesity. We've had renowned bariatric surgeons on, we've had renowned cardiologists on, we've had just a lot of really awesome people. Zach Ritano, the CEO of Ro, the online telehealth juggernaut, was on not this past Thursday, but the Thursday before, sharing about the GLP-1 tracker. We just had a lot of really awesome guests come on the show. So that happens every Thursday night at 9 p.m. over on YouTube. So if you're not subscribed over on YouTube, make sure that you subscribe and hit the bell notification so that you're reminded that we do that every week. It's a really great time. Put OTP in the chat if you enjoy On the Pen Live every week. The other thing that we do is a weekly podcast. The weekly podcast is called On the Pen, The Weekly Dose. And so you can find that wherever you find your podcasts. It is an absolutely awesome podcast where you get in a 15-minute, bite-size podcast all the weekly news for incretin mimetics, at least the ones that I can fit into that 15 minutes. We've cracked the top 20 several times. So the top 20 podcasts in all of medicine in the United States, we've topped that twice. And so if you could help me continue to do that, you can do that by going over to Apple Podcasts, Spotify, Google Podcasts, wherever you get your podcasts, and download it and then give it a 5-star rating and review. I really want to crack the top 10. And to give you an idea of some of the names that are in there, it's not an endorsement of them, but you got Peter Attia, Dr. Paul Saladino, RFK Jr., and then, little old On the Pen, we've gone as high as 12 on the charts. So you could help me out by going and giving a 5-star rating and review and downloading that podcast. Miss Moni, Regbub, Samantha, all love On the Pen. Mimi, Allison, Tammy, Johnny, Cloakster, Gino, Megan, Gina, all love On the Pen. So thank you for being here. Really, really appreciate that, and really appreciate you being part of the weekly show that we do on YouTube every Thursday night. Go back and check out that interview with Zach Ritano. That was one of my favorite interviews I have done. We also did a really good one with Dr. Michael Albert about 2-3 months ago. That was really good too. Just the ones where I get to nerd out with other people who are as obsessed about this topic as I am. And I'm obsessed about it because it's changing lives, right? You can't interact with the amount of people that you do like I do on a weekly basis and hear about the lives that are being changed by this class of medications, and not want to just continually spread the gospel, because there are more people and more people and more people that this can help. And I'm a firm believer that we are doing that at On the Pen. And it feels so good to have been given this opportunity by you, those of you who follow my channel, those of you who subscribe over on YouTube, those of you who are members, the paid members of this channel, who are the ones who really make it happen, right? The ones who are finding the way to join the channel and give $2.99 a month. It helps to support the work that I do. And those who also visit onthepen.com, my website, where we have tons of stuff. So thank you for being the best part of what we do here at On the Pen. I'm going to hang it up. It's been great spending part of my birthday here with you tonight, my 39th birthday. It's been so good to spend about the last 2 of those years with all of you, and thank you for giving me this platform. I couldn't, wouldn't, shouldn't do it without you. I really appreciate you. Until the next one, have a great one, and we will see you again on the Pen. Check you later.